So I'll be speaking on ciliary sulcus fixation of the IOL with optic capture. So now, as you know, the patient's expectations are very high these days. Gone are the days when you can come out of the operating room and say, we could not put the IOL. Lens nahi lag paya. There are so many options, and that is what this course is all about. That you have to put the IOL before you come out of the OT, after you have finished the surgery. But whatever the IOL may be, whether it's sulcus fixated, SF IOL, iris fixated, so many things which Abhishek said just now. So the development of IOLs designed specifically for placement in the ciliary sulcus continues to be an area of interest for the ophthalmic industry. While we are using a lot of these IOLs and putting them in the sulcus, we are especially trying to design IOLs which will be less traumatic for the eye once we have them. Currently, the one-piece PMMA lens or a three-piece IOL are the best available options for IOL placement in the ciliary sulcus space. Now, it's very important to understand the anatomy of the sulcus once you are putting these IOLs. The endoscopic imaging and the ultrasound biomicroscopy have enabled a better understanding of ciliary sulcus anatomy and measurements in the living eye. When the capsular bag is compromised, IOL placement in the ciliary sulcus is a reasonable option. In these circumstances, appropriate choice of the IOL, knowledge of the sulcus anatomy and correct technique can improve results and reduce post-operative complications. It's not so much a big deal to put the lens in the sulcus as is to make sure that there are as less complications as possible. The anatomic zone for optical placement for intraocular lens implantation is within the capsular bag, as we all know. It's universal knowledge. This provides the greatest IOL stability and places the IOL closer to the nodal point of the original crystalline lens, resulting in better image resolution. When the IOL cannot be securely placed within the capsular bag, an alternative positioning and fixation is required. In cases of posterior capsule rupture, zonular laxity, lens subluxation with absent capsule or planned piggy bank IOL placement in the ciliary sulcus is preferred. Now, this is a anatomical representation of what you will see actually at the end of the surgery once it's finished, is such that the haptics are in the sulcus, and you can see that gray line, and the optics are behind the anterior capsule, and this holds and maintains the capsular stability, the IOL stability. When there is zonular dehiscence, if the area of zonular dehiscence is less than 3 clock hours, a conventional CTR can be placed in the IOL with the IOL in the capsular bag. If the CTR is not available, IOL can be placed in the sulcus. If the area is greater than 3 clock hours, a capsule tension ring can be sutured, or a modified Sionis capsular tension ring can be used to attain stability for capsular placement of the IOL. If these are not available, sulcus IOL placement can be attempted with a low threshold for iris suture fixation of the IOL. If the posterior capsule tear with intact anterior capsule is there, then there are two options for the sulcus placement and one for in the bag placement. One sulcus option is to place the entire IOL in the sulcus, and the other option is to place the haptics in the sulcus and gently prolapse the optic in the bag with a centered anterior capsulotomy, and that is what we are talking about, IOL capture. With the optic in the bag, no IOL power adjustment is needed, and the optic capture is stable and seals off vitreous from the anterior chamber if any is coming from the PC tear. If there is a defect in the posterior capsule, the haptics should be oriented 90 degrees away from the defect to prevent the haptic from sliding into the area of the concern. So with the good red fundal glow, this is what you will see of how the IOL is placed. The haptics are in the sulcus, and the optic is behind the anterior capsule. Now, what are the contraindications to the sulcus IOL implantation? Lack of anterior capsular support. When the anterior capsule is not adequate, alternative fixation techniques need to be used. If there is no capsule support, iris fixation, scleral fixation, or an ACIOL can be used, although the latter should be avoided in patients with shallow AC and compromised cornea, which is common knowledge that we should not use ACIOL in these patients. Most severe complications related to sulcus IOL placement arise from poor choice of IOLs, particularly placement with single-piece acrylic IOL implantation in the ciliary sulcus, have been reported to develop secondary pigment dispersion and elevated IOP and secondary pigmentary glaucoma. Analysis of several sulcus fixated single-piece acrylic IOLs that were explanted because of pigment dispersion revealed that the most common histopathological finding was pigment granules on the anterior surface of the IOL. This accumulation was greatest on the haptic but also appeared on the peripheral optic and haptic-optic junction. These findings are consistent with the posterior iris chafing caused by the optic and relatively thick flexible haptics, all of which have squared edges and unpolished side walls. ठीक है, 1 मिनट इसका ये ऑफ होगा स्क्रीन. 1 sec. ठीक है, ऑन कर दे.
Three-piece IOL in the sulcus.
ये नहीं आ रहा है इस पर वीडियो. स्लाइड शो नहीं है, ये वीडियो अलग से. उस स्क्रीन को ऑफ कर दीजिए अभी. ये स्क्रीन को उस पर कैसे आएगा?
As in case of PC rent. Now while phacoemulsifying the last piece, I encounter a PC rent.
It's 8:15.
Okay, so there's some difficulty in running the video. So basically I wanted to show that this is how it appears once you have the, and also keeping this picture in mind, at the end of the surgery, it's very important that you put some triamcinolone and do an anterior vitrectomy when there is a posterior capsule rupture. Thank you very much for your kind attention.
Thank you, Dr. Satyajit, for the nice presentation. I would just like to ask you, which is your preferred IOL in case of the posterior capsule rent with, if you want to do an optic capture?
I think a 3-piece IOL is the best option. Once you are putting, it was there in the video, we would have shown it, but a 3-piece IOL is one of the best options. Definitely there's a big no of these the single piece IOL which is there. If you don't have it in the OT, those 3-piece IOLs, then you wait, make it available and you can do it in the second sitting. But try not to put the single piece IOL for in the sulcus.
So is there any reason for not going ahead with the single piece IOL?
The centration, the placement, the stability, most of all we are talking about the stability, is much better than with the 3-piece IOL than is seen with the single piece.
And another common question comes in the mind, that what about the biometry part? Do you change any when you are planning? I mean, you have already planned for the in-back placement, now you are...
So in our day-to-day practice, when we are doing biometry, we do not take into account that there will be a posterior capsule rupture, and suppose we are doing a scleral fixated IOL or a some other thing, then with the A scan we should do this or we should do that. We do a general biometry and see how much the IOL power is. But in this case, I showed you that once you are putting in the sulcus the haptics and the optic is in the bag, behind the anterior capsule, then the IOL power will remain the same because the effective lens position will be the same as in the bag. So the IOL power remains the same.
Yeah.
So another point which is very important, Dr. Satyajit said that you need to put triamcinolone and look for any vitreous. And if vitreous is there, you definitely need to do anti-vitrectomy. So thank you, Dr. Satyajit.
Thank you very much.